Just educate yourself.
They were at the office all the time.
That case was stressing me out. You couldn't find a worse thing to do to a patient. I've done some research on 3-on-6. I'm not trying to attack it by any means, right? But the funny thing is that all-on-4 is wasn't it started by Nobel, right? The terminology? Yeah, Dr. Palomalo invented the concept, but I believe the Nobel, the implant company, could just, it's kind of like Kleenex, right? It's a tissue, but we call it Kleenex a lot of times. Or back in the day, like Sony kind of became synonymous with like a lot of TVs and stuff like that. But 3-on-6 now seems to be synonymous with individual implant bridges, right? So what are your guys' thoughts in regards to, because I have mine and I'll share those in a second, but let's talk about all-on-4 versus 3-on-6. What are your thoughts in regards to, offering, because again, managing expectations, predictability, and also long-term result? What are your guys' thoughts? Let me get your thoughts on that.
Yeah, there are 3 individual and separate bridges, and they can be either on 6 or we can also place more 8 implants and have some single teeth as well. So the whole, the advantages is, first of all, that they have only teeth replaced, no gum replaced, so they can actually show their natural gum. The other advantage is that in case they break something, they will just have to replace that specific bridge that contained that tooth that broke. So they don't have to repay for the whole thing, and they don't want to go to that whole process of just getting a new prosthesis, because if they break an hollow neck, they need to have a replacement of the full set of teeth and gums.
So you're talking about that from a dentist standpoint though, yes. Right? So a patient won't care. So if we're doing a 3-on-6 versus all-on-4.
And the other thing is that if they have a lot of teeth that they're actually have missing for a long time, they're gonna also have a lot of space in the mouth. In this case, they can do 3-on-6, because in this case they will have to replace also gums and also the tissue that has been recessed and is missing for all these years. Another thing to consider when we're gonna have to see which option we're gonna go for.
Okay, so this can get really technical, so we don't want to confuse the people out there. So let's take a step back. Let me ask you a quick question. If you were to, your grandmother, half her teeth missing, and now, a prosthodontist, you have the financial resources, you tell your grandmother over in Greece, hey, fly over, and we're gonna take care of you. Without looking at her, what do you think the most predictable option is gonna be for her? Is it gonna be an all-on-4 or a 3-on-6?
All-on-4.
Okay.
For my
grandma. For predictability.
For
the surgery, and also let's talk about, I don't know how old your grandmother is. How old is your grandma?
About 80.
80, okay. So you wouldn't want her to be in a situation where 5 years, 7 years from now, if she slows down a little bit more, I'm sure your grandmother's in great shape, but if she's slowing down a little bit more, that she then starts having more dental implant issues, and now she needs to come into a dental office with kind of decreased health and putting more stress on a person. Let's talk about that perspective. What do you think can give you more predictability over the long haul to not give your grandmother issues? In individual implant bridges, like a 3-on-6 or all-on-4?
All-on-4. First of all, the treatment is gonna be, it's not gonna last long, because 3-on-6 you have to take care of bone recession, and you have to take care of a lot of bone grafts that you have to do, tissue grafts and stuff. All-on-X is gonna be much more straightforward and a very shorter period of time that she has to heal and take the final teeth.
Okay, so you're saying the surgical process, even before the path, basically, right, before you get to your final product, you're saying that from day one where they come in for their initial consultation or their exam to the day that they get their final set of teeth, that they're all screwed in and good to go, fly back to Greece, that period of time is a lot shorter with all-on-4, correct? Right, we know that, right? Fortunately, the staff, a lot of people, the folks out there don't know that. But the other thing...
Plus is the hygiene.
Okay. But the other thing is that process, that's a complicated process, right? It is. If we were to provide that, and we do provide that option. We try to steer the patients away from that option, right? But it is a lengthy process. I met a patient who, I think they're from a few hours away, 3-4 hours away here, but they're still in Texas. But the husband had 3-on-6 done. And he said it took him 2 years to get finished, and there was all these things that happened versus his wife's all-on-4 process. So completely different journeys. Now, we'll have conversations about it later on in the day. Sometimes things can happen with all-on-4 also that can lengthen the process too. The whole objective of this conversation is to let people know that every option that we choose can have a pathway that can be longer than expected, right? There's things that can happen 100% before we can get you that final final product. But if we were to make a blanket generalized statement in regards to what pathway could get you the most predictable response the fast, then we'd all agree that it was all-on-4, right? But it's not always about fast. Like for me, I actually don't care how long it's gonna take as long as it's done right. Because again, I don't have time to like mess around with things. So if you give me an option that's gonna be the most predictable option, 100%, then with me being the guy that's doing the surgeries and all this stuff, then I'm gonna say all-on-4 all the way. What are your, I wanna hear your guys' opinions in regards to this exact same.
Well, the same thing with the doing the surgery part, right? I think there's less room for error for an all-on-6. For 3-on-6. 3-on-6, because the teeth literally have to come out perfect. And when they don't, what are you doing? You're gonna have to graft, socket, and you're gonna have to wait for that bone to regenerate and heal up, and then go back into it again at a later point in time for it to be even a success on that point.
Right. So we will make videos in the future talking specifically about that, but we know for a fact that when you're doing individual implants, you have to, we're doing immediate dental implants. When you said that there's basically less room for error on a 3-on-6 or implant bridges, we have to, especially the anterior implants, they have to be placed more palatally. We have to make sure that we have good buccal bone, right? We have to make sure that maybe we have to graft that. And then here's the kicker on top of that. Are we gonna have the certain amount of torque that is necessary to load those implants immediately? And so the problem with the 3-on-6 or implant bridge option, so you gotta at least do 8 in my opinion, is that would you place those implant bridges, like the prosthetics, so temporizing and managing expectations? If I was to tell a patient that we are going to do, let's say we're not gonna do, in my opinion, 6 implants isn't enough up top. We're going 8, okay? So we're doing 8 implants. We're doing implants every 3 teeth. So we have a fake tooth in between. Now, again, if we're doing every 4 teeth on the back, in my opinion, that's definitely not good enough, especially if we're doing immediate implants. Are we gonna generate enough torque, especially on cases where patients have low sinuses? Most people have low sinuses back there in that area, right? So do they need sinus lifting also? Do they generate enough torque? And then, because there's not any bone reduction or very minimal, we now are gonna temporize those teeth with whatever material, and it's gonna span 4 teeth. We had conversations about this earlier, right? There's that prosthesis, or the teeth would be breaking like crazy during those 4 or 5 months of healing. And you said you saw that, right?
Yes.
Yeah, you've seen that multiple times. And so if I was to create a option for a patient or a solution for a patient that would drive my patients crazy and make me again pull my hair out over the next few months because they're constantly upset because they're coming in all the time. It even happens with all-on-4 sometimes, right? The prosthesis can fracture. We want to again manage expectations. That prosthesis can fracture when you're in that temporary state, but that thing's a way, way, way thicker versus a 3-on-6 or implant bridge option temporary prosthesis. Number one, did we place those implants palatally, especially in the anterior, so we don't have any aesthetic ramifications? Did we generate enough torque to do immediate loading? And again, if we're not, then that patient's gonna have to wear a denture. Then they wear that denture for 4 or 5 months after all the implants have healed. Then we do the uncovery process, we bring them in. We have another surgery to do the uncovery process. And then also, we're probably gonna want to mold the tissues.
Shape the papillas.
Right, shape the papillas, and then, create Pontic sites and all this stuff to make it more natural. Otherwise, your teeth are gonna look straight up like chiclets, like just pure square teeth, and that would be unsightly. Now, most people have low smile lines, but still. And then there's other cases that are, that we've also seen where patients or doctors, they'll be like, well, I'm gonna create papilla for you. And we even have images like that you showed me that one time of a doctor who did phenomenal work, don't get me wrong, but you're kind of defying the laws of biology when you're expecting 6-7 years later for the papilla to be completely intact, giving you all these beautiful, the papilla and the bridge looks, fantastic, right? So you're kind of defying that law of biology, and when you do and you create those the Pontic sites and you're creating the basically the lower contact points so it's not as high, so you can have your papilla. Well, over time, as this your tissues retract, that just creates food traps, right? And I can just completely imagine a situation where you're eating pasta or bread and all this stuff is getting caked on the front of your tooth, right? And so and how subconscious you would be, and I remember you showed me that image. But there's a lot of nuances when it comes to 3-on-6. Stay tuned, guys. I will make a video where we're gonna go way in depth in regards to, again, this is not an attack on 3-on-6 or anything like that, but just the concept of implant bridges and versus like all-on-4, because I noticed that more people are talking about this. You know, one thing that I think is a very important point is understanding that there's a lot of dental offices that try to go purely all-on-4 center, that go purely snap-on denture center, that go purely, we don't mess with either of those options because we're just gonna do implant bridges. And the reality behind it is maybe it's because they don't have a lab, maybe they don't have a prosthodontist, maybe there's little nuances in regards to like their training as to why they wanna offer certain products. We offer it all here, right? So we have no skin in the game to sell you on something like a certain treatment option. Again, we just want you to be happy. Also, we tell them, patients, from our perspective, we are gonna do what we would do within our own mouth. And here's the kicker. 3-on-6 type of prosthetics for us or implant bridges, if you come to me and you really want that, we're gonna charge you way more money. It's way more stressful than surgery, right? Like way more chair time, liability, long-term, right? As the owner of the practice in warranting my work, I mean, now my stress level's here, right? Because we all know placing one anterior implant to make sure that that implant stands the test of time, that doesn't have bone recession, that doesn't have soft tissue recession, that we can get the aesthetics matching right. I mean, that's hard enough on one single tooth, right? And then when we're trying to take out multiple teeth, like let's say the patient up top has 14 teeth, taking all those teeth out, preserving the interproximal bone, preserving the buccal bone, oh wow, like you stress the hell out of me now.
Yeah,
right?
That, and you're expecting the patient to heal, right? Because that's a huge factor in all this too.
Right.
It's like we can do the best job we can surgically,
right,
but at the end of the day, we're not going home with you. We're not making sure that you're doing everything that you need to do to preserve everything that we did in the office. And that's a big play in everything that we see.
You could do the best ACL knee surgery and your patient goes and plays basketball next week. As ridiculous of an analogy that is, we got patients that don't take their antibiotics after the procedure. They start eating whatever the heck they want.
They smoke.
They smoke, and it's frustrating, right? Because, you know, we're talking about, even from a predictability standpoint, the all-on-4 is way more predictable. At a patient, she was, you remember her from 2 days ago, the one from Virginia. I mean, how many all-on-4s do we do? In that case, was stressing me out, right? Her sinuses were huge. I had to nail those 2 pterygoids. And not only were her sinuses huge, they drift very far anterior. She's 37 years old. We're not jumping to zygos immediately, right? So it's like, from a stress standpoint, like patients, like, you know, and I've seen these on YouTube comments like over the years. They're like, dang, you guys charge so much, and like, why do you guys charge so much? And it's just, there's so many aspects of the game in regards to, like, you know, that affect our overhead, but also when we also warranty our work and we're also liable for that long term. And we're, again, when we treat you to make sure that you have a predictable result in the end, to make sure that you have the beautiful, it's got to look good too. Like, you're not going to be happy. You're like, what the heck is going on with my gums right here, where my gums are really receded and my bone is lost? And I tell you, well, you're chewing okay, right? They don't want that answer, right? I mean, what are your thoughts?
And also, one of the most commonly asked questions for me is, Doc, is this gonna last my lifetime? Usually my answer to that is, well, with the all-on-4 teeth, we have about 25 years of data, nothing more than that, because, you know, I think it started in like the late 90s or early 2000s. Yep. So is this gonna last 60 years? I'm not so sure. So I usually try not to give like a definitive answer as to say, yeah, it's gonna last for a lifetime. I can't promise that.
But what you can do, though, is you can prepare that patient to make sure that they don't have any issues, and that's why we'll place more implants sometimes, right? That's why we call all-on-X. We'll place 6 implants. Like, I placed 7 implants on that patient from Virginia the other day in their upper arch. I think 5 on the lower. And there's even cases that I look at from like the 90s, or like early 2000s, with like implant bridges or individual implants that have no bone loss whatsoever. But when we do our all-on-4s or whatever implant options that you're doing, just being smart about it. And this is exactly what you're talking about, is a key point. Ability to provide a long-term prognosis when we do like a full arch of extractions, like a full upper teeth or lower teeth of extractions, and preserving all that bone. Like, why do we talk about bone all that time, right? When I go to perio conferences, when we're talking about long-term predictability of implants, that bone and soft tissue, the gums, dictates everything, right? We know that. And that's why when we're doing these surgeries, we have to be super paranoid. You know, palatal placement, thick buccal bone. If it's not enough bone there, and then we're like doing like ridge augmentation, GBR, doing all these things, and we're trying to preserve the interproximal bone. I mean, and the predictability aspect, God, I've extracted a scary amount of teeth in my career. Even when, again, the patient from Virginia, 37 years old. Not to sound morbid about things, but what is the average lifespan? 80 years old. So now we're talking about I need to get something like a 43-year lifespan. This is longer than All-on-4 has been out there. But we've seen patients that have had All-on-4 for 10 years, like, you know, and they have amazing results, no bone loss whatsoever. So why wouldn't it be able to last like the test of time? But the procedure has to go very well. That's why when I'm taking the teeth out, I was sweating. Right? You saw me during that surgery, you know, and because I want a good result. You know, I'm picturing myself in that chair, right? And the predictability on that is, from our surgical perspective, way easier for All-on-4, right? You sweat way less for All-on-4, like surgery versus implant bridges, right? And you know from your perspective, like if you had to bet money on us doing the surgery to set you up to do a good prosthesis, you would say that All-on-4 is gonna be way easier too, right?
Way easier, yeah.
Yeah.
I can manage the angulations of the implants because of course implants are placed according to the bone. It's not only like the skills of the surgeons, it's where the bone is. So if the patient has resorbed bone in an area, of course we can place the implant there. So it's All-on-X is much more manageable. To look good, to feel good, to have the screw access holes where we want them, compared to a 3-on-6.
Right. The screw access holes, which would then which are the multi-unit abutments.
Exactly.
Right. So how that comes into play. There's so many nuances that what we're trying to do in this video is let patients be aware of things that can go wrong. Now, I'd seen some photos online, and again, I'm not trying to attack anybody's work here, but I'm just looking at the prosthesis, and I'm also looking at like the surgery that they're doing, and I'm sitting there and saying, what's actually going on behind the scenes, right? So with the dental implant, unless we have a 3D scan, when we could see like where that implant positioning is, we don't know what's gonna be the long-term manifestation. We can have dental implants, as you guys know, that look phenomenal on day one, but 3 years from now, 5 years from now, 7 years from now, they can have a lot of bone loss going on, soft tissue recession, peri-implantitis. Those are all factors that could have been prevented. It literally happens to the best of us. I've seen them on my cases too. But the way that we can get the most predictable response, and like, you know, what all our training was all about, making sure that you have, again, like 2 millimeters of buccal bone thickness, bone augmentation, soft tissue augmentation, get these predictable results so you don't get all that, you know, crazy recession or bone loss or peri-implantitis. Now let's talk about, when we're talking about implant bridges, 3-on-6 concept versus other implant bridges. And 3-on-6, or even if you do individual implant bridges, right, whether you did 3 or 4 individual implant bridges, those don't have cross-arch stabilization, right? So the concept of All-on-4, it's crazy that you can actually get away with placing 4 implants, have your whole set of teeth only on those 4 implants. All-on-4 was trying to get more credibility in, like, you know, across the United States or across the world. It was a crazy concept, right? And I remember the first time I heard it back in residency, I was like, this is stupid. I remember our plant director was in the back of the room and, like, you know, he thought it was, you know, crazy too, like as did everybody. Cross-arch stabilization is why it works, right? And so it's just a concept where basically when it's one piece unit, this is a physics thing, which I don't remember any physics. You know, it's just literally a class I had to pass to get into dental school. But realistically, you know, cross-arch stabilization, the actual physics and engineering of it, long story short, what it does is it pulls the stress off the individual implant, right? So the implant is not overloaded. And so when we're talking about overloaded, it's not like we have a fence pole that we're just constantly shaking all the time individually by itself. But when you, like, you know, stabilize it with some, like, for example, horizontal beams, like, and you have a fence, then you pull the stress off of each individual beam, right? But when we have individual implant bridges, they're getting all that force on, you know, let's say those 2 implants, right? Or whatever area. Everybody's bite's different. Everybody got different parafunctional habits. I personally clench my teeth at night. I didn't know I did it most of my life. I've never done this, but now I clench my teeth even during surgeries, I've noticed, you know? And so it's kind of a weird thing, but I've had a lot of patients also tell me that, like throughout my whole career, that they find themselves clenching throughout the day. But because everybody's different, and everyone's got different forces going on within their mouth, there can be what may work on one patient, you know, because someone's gonna say, well, I got 3-on-6, or I got the individual implant bridges in my mouth, and they're all implants, not like they have any natural teeth, and I've been fine. You're absolutely right. You could be fine, and then there's gonna be other patients that aren't. We also even had that patient, older gentleman that we were talking about a few hours ago, right? He had individual implant bridges, and I don't know how many years it's been, like 7, 8 years, whatever, but he failed, right? We literally pulled 2 implants out of his mouth. And I think he had them done at the university or another oral surgeon. I can't remember exactly what the story was. I think that one was actually done at the university like 7, 8 years ago. It's long story short, the cross-arch stabilization is a huge factor, to the point why there's now a lot of offices will place a bunch of individual implants and call it 3-on-6, but they're actually making one-piece unit, because now they know that it's got to be one unit. What pulls the stress off of the individual implant. So I would tell patients, listen, not saying it's not going to work, but you have a higher chance of failure over the long haul of if you do individual implant bridges, whether you did 3 for a 3-on-6 or you did 4, and you break them up into individual implant bridges, you have a way higher likelihood of failing. Would you guys agree with that? Like, again, it's what are you shooting for? If you're shooting for a lifelong solution, then I would definitely steer a patient away from that direction. If you got a 75-year-old patient who says, I really want individual implant bridges, and that's what I want to do, because we have some patients that are like that, we can do that for you. But we're going to have to do one-piece unit. Well, I mean, individual implant bridges, because they don't want to do all-on-4 because of bone reduction or whatever. And let's talk about that. Then I'd say when we do your teeth, it's got to be one whole unit, just like this. It can't be segmented individual implant bridges, because that's going to put a lot more stress on your implants, and your implants have a higher likelihood of failing. What were your thoughts in regards to implant positioning and stuff like that? Like, let's say implant bridges 3-on-6 versus all-on-4.
Yeah, the teeth have to be in a specific position in the mouth so that they are aesthetically pleasing, and they're also functional, speech-wise and also chewing-wise. For the patient.
For implant bridges?
For everything.
Okay.
So in order to achieve that, we have to make sure we have support with the implant. So if we place 6 implants and we have to split the 3 bridges, we have to make sure that all of these implants are placed at the positions that we need, so that these teeth are supported.
Exact positioning. Yeah. Way less room for error for us.
Exactly. Right? Less room for error. And for comparing on 4 or on 6 prostheses, you can actually get that component called multi-unit and fix the positioning, the angulation, and everything of the implant, so that we don't compromise the aesthetic. Because the patients need to have lip support, they have to have a beautiful smile, they have to speak normally. So I feel like if the patient is not very good with hygiene and have their teeth preserved, their gums preserved, their bone preserved, it's very difficult to achieve that to an older patient that doesn't have also the dexterity to go in and floss in between these 3 bridges and maintain everything we're gonna give him.
Okay. You brought up a very key important point. So when these patients come in, once we're done with the surgery and we do the handoff to our prosthodontist, they are looking for, especially on our female patients, right? They're looking for the lip support. In a day and age where everyone wants fillers and all that stuff, make the big pouty lips and stuff, but that lip support is huge. If you take their teeth out and their lips or this sinks in, they're not happy about that. Right? So your teeth have a positioning, right? So bodily positioning, whether it's angling your teeth or whether it's positioning your teeth further out, that has a huge impact on how full your lips are, and also the wrinkles. Yeah. Right? Because your face will sink in a little bit more. So then the wrinkles, okay, that I know I just caught your attention right there with the wrinkles, right? So I mean, in a day and age where we spend billions of dollars on wrinkle cream, this is a huge component to that. Right? So when we're doing dental implants and we're placing them in your jawbone, and again, everyone who's coming in is different. This guy's got periodontals, he's had a lot of severe bone loss. This guy had trauma, he had a car accident, or he lost it through a baseball accident years ago, so he has way less bone. This guy has relatively healthy bone, or he just has a thin biotype. All these things, I know it sounds super confusing to the people out there, right? But that affects whether we do bone grafting, all these things. And so if I'm to do implant bridges, even if it was all splinted, then again, we have to do immediate implants, we have to do palatal positioning and the anteriors. All these factors come into play. And even when we do that, I can't do that easily on a patient that had trauma, that's been missing their teeth for years, on a patient that had severe periodontal disease who has bone loss, who's lost interproximal bone, all these things. And I know it's very hard to explain to these patients on video. Can't get them what we need to get them that's gonna last over the long haul. Now, could I give you something that I place those implants, get you to be able to do your job and compromise you, oh heck yeah. I'm gonna totally, like, now you're functioning with one hand tied behind your back. And then what ends up happening is that patient starts having issues a few years later. And then that patient's really upset later on down the road because they're thinking, what the heck did I spend all my money on when I'm losing implants or I'm having these aesthetic ramifications? So we're gonna have one pissed off patient down the road. And if I'm trying to avoid that pissed off patient from happening, then we gotta go all on 4. So what you mentioned was a key aspect. Someone's out there is saying, okay, so how are you gonna fix that if the patient's got periodontal disease and they have the bone loss, or they have trauma, they got a lot of buccal bone loss, or the ridge is very thin, or whatever's going on? How are you gonna fix that with an all-on-4? Well, the first option, we could potentially fix it with a lot of guided bone regeneration, a lot of extensive bone grafting, sinus lifting, whatever the heck we need to do. But guess what that is? Way more time, that's way more money, that's more surgeries, which does not sound appealing to anybody.
And the highest level of compliance on the patient's end.
Right. And so the aspect for us to be able to achieve that is like, with all-on-4, we can then place those implants where the bone is. Again, maintaining your 2 millimeters of buccal bone thickness. Not saying you never need a bone graft for an all-on-4, sometimes we do, obviously. But to be able to predictably place that implant where I know that implant can last as long as possible, to make sure that it's not going to lose a lot of bone over the next few years, because we know that now you're set up to do your job properly. So all-on-4 can really be used in that sense, right? So that's a key component. And I know that any prospective patients out there that are listening or looking at any of these options, hopefully we can simplify this enough so that they know what's actually going on behind the scenes. Because in the end, again, we just want the patients to have a predictable result, meaning they don't have issues. And again, not saying that all-on-4s or implant bridges or snap-on dentures are always riddled with issues. No, but there can be issues sometimes. And the goal for us is to minimize that as much as possible, right? Now let's talk about one key thing is, I was checking out the website for 3-on-6. One of their attacks on the all-on-4 is gonna be bone reduction, and it's gonna be intaglio surface, underside, so food debris. Cleansability.
Yeah.
I think that's pretty much it. What are your guys' thoughts in regards to that? And then I have my thoughts. Let's start with bone reduction.
Well, bone reduction, it's like even if we just don't even do, the material needs a certain amount of thickness, right? Before we can go, whether it's a dental crown or anything like that, we have to trim either teeth or bone to a certain amount of the thickness, just so there's a strength of material.
Right. So it doesn't break, because it's got to have a certain thickness. Yeah. We had that video recently where we drove over it, right, with Dr. Ku's car. Yeah. And it didn't break, right? Because zirconia is strong.
But imagine if we did nothing, right? And now there's 2 options left for the prosthodontist or for the team that's restoring your mouth. We can make your mouth really full, compromise the aesthetics,
and mess up your jaws,
causing TMJ issues.
Yeah,
correct?
long term. Yeah.
Right? Or just giving you something that's not going to work. So to make everything well for the implant and everything in mind, bone reduction is needed for the material.
Right. So what are your thoughts? And then
So I would say, if done properly, the 3-on-6 option can work, but I think there are several conditions that have to be met. For example, case selection is key. Somebody that shows a lot of gum tissue when they smile is probably not the best candidate for this type of work.
100%.
Yeah. And then also you got to go to a provider that does this type of work a lot. You got to have a highest level of expertise, especially to execute this properly. Mm-hmm. So the surgical aspect is very important, but also the prosthetic aspect is very critical too. So you gotta go to somebody that potentially can do both very well, or maybe have to be seen by 2 different specialists, surgical and prosthetic specialists that do this a lot.
Right.
And then third point is that patient's compliance has to be very, very high. Right. So they gotta follow all the instructions very carefully, the instructions from the provider very carefully. But let's be real here, a lot of patients in general do not always follow instructions carefully.
Right. So yeah, you're saying that there's a lot of things that have to go right.
Yeah.
Right.
And the one more thing is that, if you have all the time in the world and if you have all the money in the world, I would say it can work for you, but that's not the reality for most people.
So the stars have to align.
Yes.
Right. Mm-hmm. And so I know there's another guy in Dallas who does a lot of these and preaches them extensively too. And from word on the street is he charges for it, and it's very, very expensive, right? And as we offer too, but and patients are interested in it, and they see the price tag and they're like, oh hell no. Right, that's what happens a lot of times. But it's what you bring up as an important fact is so you said the surgical component, the prosthetic component, and they have to be done very well by very experienced people. So can that patient out there find that perfect team for that. I remember when I was in Ohio, like we were talking about, I was talking to this guy one time and he was like, if you have a house built for you, then get an Amish person to do it. And I was like, that's an interesting concept. So like for here in Texas where we have foundation issues, we need to get that foundation laid perfectly for your home to never have issues. So are we gonna try to build a house that with these crazy rainstorms down here and the winds and tornadoes sometimes, can we build a 100-year house? I think it could be done, but it has to be done very meticulously by people who really, really, really know what they're doing and are well experienced.
Then you have to care about what you do, right? If you don't care, you don't put yourself in the position of the patient, thinking like that could be my mom, that could be my dad one day, And it's like if you don't care what you do, your work is not going to be able to show it.
That's a key aspect. That's a whole nother conversation, right? I mean, you need to go to a provider that gives a damn about what they do, that takes pride in their work, that can put themselves in that person's shoes, like as if, again, your mother or father. And then also you have to have the proficiency to be able to do it, because you can care all you want, but if you don't have the experience in doing this, what good is it, right? You could have all the best intentions in the world. So there's so many factors that come into play, right? Here's my thought of all on fours. And this is like my grievance is there's a lot of marketing going on behind the scenes. So marketing as to, hey, get your zirconia teeth in 1 week, which is lunacy, right? We'd all agree on that. And there's no way in hell you're putting zirconia teeth in. If I ever needed all on four, there's no way in hell you're doing zirconia in my mouth in 1 week. With the bone and tissue remodeling, with the weight of material, you couldn't find a worse thing to do to a patient. Another key marketing point that I've seen is that people will try to talk up implant bridges versus all on four by saying, look at all on four, they got to do bone reduction. Now, let's be very honest about this topic. We've seen some bone reductions that are scary. The surgeon is literally just wiping out like a ton of bone. Even some things that wouldn't, you would see in a horror movie where they basically saw off all the bone where the roots come out with it.
Some people do that to just look cool on Instagram.
Right. I mean, it's like, I'd say it's that and zygos that are always the things that people want to post on Instagram. And it's funny because as many arches as we do, we really, really, really try to limit the number of zygos, that last ditch option that you try to use for a patient. And that's again a topic for another video. Bone reduction. I've gotten way more conservative with bone reduction. Things that I analyze obviously are going to be smile line, number one. Yeah, basically smile line, right?
Patient's age, right? So
right.
If they're too young, you don't want to be hacking off.
Oh God, yeah, and that's another thing too. That's a very key point. Patient's age is a huge thing. I mean, if you are trying to hack off a lot of bone, and then if God forbid, if you place 4 implants or 6 implants up top or whatever, and you lose an implant, do I have enough bone to place another implant? That case that we had from Virginia, again, she's 37 years old. I just started packing bio-os everywhere, because bovine bone is low substitution. That bone's really going to be there still, even if you go revisit 3, 5, 7 years later. Even though I didn't place implants in her sinuses, I did trans-sinus, but I did sinus lifts on her. I'm not a pessimist about things, but I'm always trying to kind of act in a way that, okay, God forbid, she's 37 years old. If she was to lose an implant, do I have an option here? Well, I lifted both sides, and I did a huge sinus lift on the left side. And then also one day, and then we could use that. And God forbid that goes wrong, then we could do zygos one day, right? Having contingencies for contingencies is always a key aspect when we're doing surgeries. So again, we can set you guys up for success. But very key important point, if we go around, start reducing all the bone, acting like we never need any contingencies in the future, I think that's just a very irresponsible thing to do for the interest of the patient. Were there any other concepts, guys, I wanted to discuss in regards to whether all-on-4 and snap-on dentures, or maybe implant all-on-4s versus implant bridges such as 3-on-6?